with us. And, due to all such circumstances, we still continue filling lists of groups. You know that groups completely changed, because first we organize groups for offline classes who are here. All students who are still out of Volgograd, you will study online groups. That's why actually all groups mixed, and you should be you should know which new group you are, which new group you are to attend appropriate classes. Okay, now let's talk again about our gastroenterology. Let's talk about our propedeutics lecture, and let's talk about new topic. New topic is gastrointestinal disease. The previous semester we'll talk about cardiology, we talk about pulmonology, and today we start new topic, gastrointestinal disease. Gastrointestinal disease. You know, the disease of the abdomen are very common. For example, in developed countries, approximately 10% of the adult male population is affected by peptic ulcer disease. It's not a benign disease. You may die due to bleeding caused by peptic ulcer disease. If we talk about other gastrointestinal problems like dyspepsia, it's very difficult to find someone who never experienced dyspepsia or who never experienced food poisoning, for example. And all this is gastroenterology. And as usual, when we start new topic, we start talking about clinical approach to gastrointestinal symptoms and signs. You know that you start your work with your patient, asking him about his problems, asking him about his complaints. And that's why let's start talking about complaints of patients and complaints. Actually, this is symptoms. All complaints are symptoms. Complaints or symptoms and signs of gastrointestinal disease. Now, this is list of such disorders. Actually, you know that in our real life, usually we use term dyspepsia or indigestion. Dyspepsia, indigestion. And dyspepsia, the term used by healthcare workers to describe upper abdominal symptoms, such as nausea, heartburn, acidity, pain or discomfort, wind, fullness, belching. So patients seldom use the term dyspepsia, and they're more likely to refer to indigestion to describe any symptoms that is food related. Indigestion is common. 80% of the population will have had indigestion at some time. No, 80%, this is scientific report. I believe that 100% of population will have had indigestion at some time. So let's start describing each complaint. Now let's start from nausea and vomiting, for example. Nausea and vomiting. No, there are three phases. Nausea is a feeling of wanting to vomit. The nausea feeling of wanting to vomit, often associated with autonomic effects, including hypersalivation, pallor, sweating. Then we have retching. Retching is strong involuntary effort to vomit. Strong involuntary effort to vomit, which is known as retching. And finally, vomiting. Vomiting, the expulsion of gastric contents through the mouth. Expulsion of gastric contents through the mouth. You see, we have a huge number of possible causes of vomiting. Possible causes of vomiting. First of all, you know that all animals, all creatures can vomit. You know that in our brain we have even special vomiting center. Just believe, in our brain we have vomiting center. We have, for example, breathing center and we have vomiting center. It means that vomiting is something very important for us. Why vomiting is important? It's not actually very pleasant experience to vomit. Usually we may believe as vomiting as actually protective reflex. vomiting is protective reflex. Idea of this protective reflex is very clear. Yeah? If you add something wrong and this stuff may be poisoning, you should immediately remove this stuff from your body. And how to remove something from stomach? Vomiting. And that's why vomiting is a very important protective reflex. And by the way, it means that not in all cases we should treat vomiting. Not in all cases we should treat vomiting. Sometimes we even should try to induce vomiting, again, to clean stomach. For example, in case of suicide, to taking some pills, or if someone ate some wrong food. No, in this case, we even induce vomit. What may cause vomiting in real life, in our clinical practice? First of all, of course, any gastrointestinal disease. All possible gastrointestinal disorders may cause vomiting. Gastritis, peptic ulcer, pancreatitis, cholecystitis, appendicitis, actually, again, all inflammatory situations which may happen in abdominal cavity, all may cause vomiting. Idea is very simple. If our brain finds out that something wrong with abdomen, let's vomit. Maybe it will help. And that's why in many cases we have vomiting, which can't help, which can't actually make some relief, bring some relief. So for example, if you have gastritis or peptic ulcer, yes, vomiting can help because it removed from stomach, which affected by inflammatory process. But if you have, for example, pancreatitis, no, we don't have food in pancreas. That's why in case of pancreatitis, sometimes patients experience severe vomiting, uncontrolled vomiting without relief. And that's why, again, if someone vomits, first of all, check gastrointestinal disease. Gastrointestinal disease. Acute infections like influenza, pertussis. Again, why? Because again, all infections bring intoxication. If someone experiences intoxication, again, our brain believes maybe this intoxication due to food poisoning. And that's why let's start vomiting, maybe it will help. Because our body has very limited number of protective reflexes, and vomiting one of such reflexes. And that's why if something wrong, our brain believes, let's vomit, maybe it will help, maybe not. Central nerve disease, like rise in intracranial pressure, meningitis, vestibular disturbances, migraine. Again, in our brain, we have vomiting center. And if we have some central nerve disorders which can disturb this vomiting center, irritate vomiting center, it may cause vomiting. It may cause vomiting. One example. Such thing as sea sickness. That sea sickness. This is when some people, they can't travel by boat, for example, or even sometimes by car or by plane, because if their body moved on waves, for example, traveling on boat, such people start experiencing vomiting, nausea and vomiting. And in a case of severe storm, for example, even strong people sometimes experience vomiting. How it can be explained? Okay, what with actually traveling by boat and vomiting? What is biological sense of this? We can find this biological sense. Remember, I told you that we have vomiting center in our brain, but in our brain we also have so-called vestibular center, because even you close your eyes and move your body, you feel your position. Why? Because we have vestibular apparatus, vestibular system, which can control our position, control position of our body in three-dimensional surrounding. So, and if you travel by boat, for example, and your body moves all the time, this vestibular center, of course, irritated a lot. And what? Occasionally, vomiting center placed just nearby vestibular center. And what may happen? These electrical impulses, this irritation in vomiting center may spread to surrounding nerve tissues. And surrounding nerve tissues nearby, we have vomiting center. And that's why patient may experience nausea, vomiting without any biological sense. This is just because due anatomy of our brain. That's why this is also central nervous condition, not disease, but condition. Metabolic causes like uremia, diabetes, ketoacidosis, all this also some kind of poisoning for our body. Again, remember, poisoning, let's vomit. Maybe it will help, maybe not. Different drugs, like you know that all drugs, sometimes you know even ancient Greek doctors, they told that all drugs means are poison. But actually, all drugs may be poison or maybe remedy. Difference in dosage. All remedies in high dosages may serve as poisoning. And that's why actually really many drugs work as poisoning. For example, digoxin, cardiac glycosides, opiates, narcotics, chemotherapy, immunotherapy we used to treat, for example, some cancer. All these remedies may be toxic, and our body believe that this is some toxins and start vomiting. Again, remember, intoxication, let's vomit. Reflex vomiting, for example, severe pain, even myocardial infarction. Remember, I told you on my first lecture about differential diagnosing, and that in some cases of myocardial infarction, clinical picture similar to clinical picture of peptic ulcer disease. And patient with so-called abdominal form of myocardial infarction, they may experience what? Pain not in the heart region, not retrosternal pain, but pain in abdomen, pain in the abdomen. And again, what may happen? If our brain feel pain in, detect some pain in the abdomen, and I explain to you why, because again, if actually infarction happened in actually part of the heart which placed on diaphragm, the so-called basal infarction, this part of the heart, due to innervation, pain goes down into abdomen, and patient feel pain in the abdomen and epigastrium. And in this case, again, reflex. If our brain detects some pain in abdomen, maybe this is abdominal problem, maybe this is stomach problem, maybe it's a poisoning. Let's vomit. We may have even psychogenic vomiting. You know, in some conditions, when patients are afraid of something or some stress conditions, patient may vomit. Pregnancy also for women's body, it may work as intoxication. The result, let's vomit. Alcohol excess, very dangerous, because you know sometimes heavy drunk people, they may die not due to intoxication of alcohol with alcohol, but due to the fact that actually alcohol excess may cause vomiting, because for our body alcohol is a poison. And at the same time, person may be in, you know, due to alcohol, stupor or sopor or even in coma. And when someone being actually in consciousness, being in consciousness, if someone vomiting, it may cause aspiration of vomiting mass. It may cause aspiration of vomiting mass. And it's extremely dangerous, because aspiration of vomiting mass may cause complete blockage of airways, and patient just die due to asphyxia, may die due to asphyxia. That's why actually, again, in many cases, vomiting may help to improve, may improve or make some relief. In some cases, vomiting is just a symptom and can bring some relief, but in some cases, vomiting itself may be dangerous, and may even kill the patient, So again, I told you that many gastrointestinal conditions associated with vomiting, but nausea and vomiting without pain, frequently non-gastrointestinal in origin. This is what I try to explain. Some specific types of vomiting. Hematemesis. Hematemesis This is presence of blood in vomiting mass. This is vomiting blood or coffee grounds from the stomach. In this case, we talk about hematemesis. Hematemesis, and this tells us about some bleeding. No, usually this is peptic ulcer bleeding or cancer bleeding, the stomach peptic ulcer or stomach cancer bleeding. Large volumes of vomit suggest intestinal obstruction. Again, in some cases, vomiting happened. Why? Because we have some obstruction. What is an obstruction? For example, tumor completely close intestine. In this case, foodstuff can't pass through. What happened in this case? Sooner or later, this foodstuff digested, collected, but it should somehow leave the body. If it can't move forward, it moves backwards. And in this case, patient may vomit, and as patient eat, drink, but nothing can pass through. All this then come out. In this case, we talk about large volumes of vomit. Large volumes of vomit suggest intestinal obstruction. Suggest intestinal obstruction. Feculent vomit. What is it? This is when vomiting mass smell as a feces, bad smell. So feculent vomit suggests low intestinal obstruction. Low intestinal obstruction or the presence of gastrocolic fistula. No, low intestinal obstruction, no, this is actually a rather rare condition. Just imagine that first foodstuff should pass through all 5 meters on small intestine, then be blocked somewhere in large bowel, and then go back the all 5 meters and then induce vomit. More often that we have fistula. What is fistula? This is hole. Remember anatomy again. Stomach and large bowel placed nearby. And in some cases, huge peptic ulcer may pass through, may cause so-called penetration, and penetrate to nearby organs. In our case, this is large bowel. In this case, finally, we have some hole between stomach and large bowel. As a result, feces can come into the stomach, and then it may induce vomiting. It may induce vomiting. In this case, we see actually feculent vomit. Chronic nausea and vomiting. Chronic nausea and vomiting with no other abdominal symptoms, usually due to a psychological cause. You know, I saw such patients. Mostly this is young girls who are eager to be very slim, to look like as a model. They believe they're too fat. As the result, even they eat something, after that they go to toilet and vomit just to remove food, Unfortunately, in some cases, it may cause very serious consequences. It may cause cachexia, when patient loses all his weight, muscles, and actually may weigh, I don't know, 25, 30 kilos, being 170 centimeters high. And finally, it may cause patient death due to psychological problems, due to this continuous vomiting and nausea. Patients even may die. That's why this is also maybe a very serious problem. Early morning vomiting. Early morning vomiting, when vomiting happens usually only in the morning, is seen in pregnancy, alcohol dependence, some metabolic disorders, for example, uremia. So it means what? If someone complains of vomiting, you should ask about what is this vomiting? What do you mean vomiting? What is the volume of vomiting? When it's usually happened? Before meals, after meals? How often it's happened? Every day, maybe once per week, and so on. So you should ask a lot of additional questions. Remember, we explained to you that actually this is complaint vomiting, and you should carefully describe this complaint, because each answer may give you some ideas. So again, feculent vomiting, you believe this is either some fistula or low actually bowel obstruction. Early morning, think about pregnancy, if in case of women's, or alcohol, or some metabolic disorders. For example, if someone complains of nausea and vomiting after meals on the top of pain, how it's usually happens. Patient eats something, then he starts feeling pain. This pain increase, becomes very severe. Then patient vomits and pain disappear. If someone presents with such signs, I can say, what is it? This is peptic ulcer disease. And usually this is stomach ulcer. The peptic ulcer disease, stomach ulcer. Why? Because food irritates this. What is ulcer? This is wound. They're just open wound on the wall of the stomach. Just imagine. If you touch wound, you feel pain. The same happens when patients eat something, food irritates this wound. It causes pain increase and induce vomiting. When food leaves stomach, of course, pain decrease. You see, you ask proper way about how it's happened, why it's happened, and you know already diagnosis. Of course, this diagnosis should be confirmed by fibroscopy, but again, primary diagnosis, usually we write based on just questioning and our physical examination. Okay, next complaint. Next complaint is flatulence. Flatulence. No, this is the term used to describe excessive wind. Excessive wind. It induces belching, abdominal distension, wind, or the passage of flatus per rectum. Passage of flatus per rectum. Why, by the way, we produce some gas in our intestine? What produces gas in our intestine? Now, some of swallowed air, aerophagy, is passed into the intestine where most of it's absorbed. No, this is a small portion of this gas. The biggest part of this gas in our intestine produced by bacteria. Bacterial breakdown of food produce some amount of gas, You know that we carry a lot of bacteria in our intestine. Everybody carry at least 1.5 kilos of bacteria. 1.5 kilos of bacteria, and most of such bacteria, they live in intestine. Just imagine 1.5 liters bottle of Coca-Cola. And all this is living bacteria which live in our body. And this is not bad, actually. Everybody believes that bacteria is bad. Let's use antibiotics to kill all bacteria. No, this is good bacteria. This is good bacteria. And by the way, number of bacterial cells in our body, 10 times more than number of our own cells. That's why it's a question, what we are. We with bacteria or bacteria with us? Not just because bacteria are very small and much smaller than many of our cells, like myocytes, for example, huge cells. But nevertheless, we can't live without such bacteria. What such bacteria do? First of all, they help us to digest some stuff because we don't have enzymes to digest everything. For example, cellulose. Or fibers. We can't digest fibers. We don't have enzymes to digest fibers. Cows, they can digest fibers. We not, because we are creatures which were constructed by actually Darwin's selection to eat meat or to eat some actually specific type of fruits or something like this. Substances which are easy digested. But we eat a lot of fibers, and bacteria in our intestine can digest these fibers and releasing some stuff which may be useful for us. Then, even more important, bacteria, for such bacteria, our intestine is a home, and they protect this home against other bacteria, bad bacteria, because we live in an environment. We eat not sterile food, we eat a lot of stuff with different bacteria. Of course, stomach can kill a lot of, because in stomach we have acid, and very powerful enzymes. But if some bacteria manage to reach large bowel with the food, with very good environment, our own bacteria immediately kill all these enemies. They protect themselves. And protecting themselves, they protect us against different infections, That's why, again, our bacteria is very important for us, Also, we believe that our bacteria continuously train our immune system. Our immune system do some training with our bacteria. So actually, our immune system all the time ready to fight. So these bacteria which live in our intestine, digestion fibers, for example, they release actually different gas. And this gas contain nitrogen, carbon dioxide, but also contain some amount of hydrogen and methane. Flatus normally pass 30-20 times per day. Sometimes people even actually don't control this and don't actually feel this. You know that hydrogen and methane, this is inflammable gas. This is dangerous gas. It may be inflammable, and in medical practice, describe cases when, just imagine, during surgery, just imagine that surgeons do some surgery for hemorrhoid, for example, in anorectal region. For such surgeries, very often, surgeons, they use not scalpels, but they use laser beams, they use electric knife, so-called, and all this is high temperature. And it was described cases when during surgery, this gas that released from patients' intestine was inflamed, it was fire, like blow up, which caused actually burning of patients, That's why be careful with flatulence being nearby some open air, some open actually fire, open fire. Okay, next and very important complaint. This is abdominal pain. Pain is stimulated mainly by the stretching of smooth muscles or organ capsules. If you remember anatomy, physiology of gastrointestinal system, you should know that mucosal layer of stomach, of intestine, contain no pain receptors. No pain receptors in mucosal layer or in inner layer of gastrointestinal system. And that's why, for example, when during fibroscopic investigation, this huge actually optic device which inserted into stomach to see what have happened, searching for ulcer, cancer, signs of gastritis. Very often, we need to get biopsy, some small piece of stomach tissues. How to get? Just special device, just cut actually, or actually take some sample of tissues. And just imagine that someone takes sample of your finger and just cut. You will feel what? Pain, because it's painful. When we do this and take a sample of tissues from patient's stomach, patient feel nothing. Why? No pain receptors. No pain receptors. That's why usually pain in abdomen happen due to stretching of smooth muscles or organ capsules, the stretching of smooth muscles or organ capsules, when actually some organ enlarged in size. For example, liver. Liver is a part of gastrointestinal system. And again, in parenchymal organs like in lungs, in liver, we don't have pain receptors. And that's why patients may suffer from very serious hepatitis or even liver cirrhosis or liver cancer, but feel nothing, no pain. Why no pain? Because no pain receptors. But sometimes patients with liver disorders, especially acute hepatitis, they presented with some right abdominal pain. Why? Because inflammation causes edema. Edema, this is what? Swelling or enlargement of liver, hepatomegaly. And liver and all inner organs, they covered with special capsule, Glisson capsule. And in this capsule, like pleura, in lungs we have pleura. And remember, you can't remember because you study pulmonology right now. But nevertheless, you should know again that in lungs no pain receptor, but we have pain receptors in pleura. And that's why if patient with lung disease experience pain, it means that we have involvement of pleura. If we talk about liver again, pain usually happens because we have enlargement of liver and stretching of this capsule, stretching of this organ capsule. Severe acute abdominal pain can be due to a large number of gastrointestinal conditions and normally presents as an emergency. Just imagine that acute abdominal pain, this is red flag. Of course, who never experienced abdominal pain? No, again, due to food poisoning, some spasms, no, everybody have experienced actually such abdominal pain, and this is benign. But in many cases, it may be dangerous because it may be not just spasm. Again, I told you that sometimes pain is due to stretching or spasms. The pain happens due to stretching of organ or vice versa, spasm of organ, spastic pain, so-called. But it may be due to very serious problems. And for example, due to inflammation, all kinds of inflammation, for example, pancreatitis, cholecystitis, appendicitis, all these may cause pain. And problem is that many of such inflammations may be very dangerous. Why? Because, for example, inflammation of appendix, why appendicitis is dangerous? No, if you do surgery, it's benign. Everybody knows that appendicectomy, this is very simple procedure, but surgeons will tell you that nothing simple in medicine. But nevertheless, if you remove this inflamed appendix, no problems. Patient recover completely. But if inflammation spread to surrounding tissues, and what is surrounding tissues? Peritoneum, the abdominal cavity, it causes so-called peritonitis, inflammation of peritoneum. And this is extremely dangerous. Peritonitis without treatment, few days, and patient die due to paralysis of intestine, severe intoxication, and patient die. That's why all kinds of pain may be due to some catastrophe. I told you about peptic ulcer. And peptic ulcer sometimes may cause perforation, hole. The ulcer becomes so deep that it causes damage of all layers of stomach, and finally all stuff from stomach, acid, food, enter abdominal cavity. Enter abdominal cavity cause peritonitis. Again, you know already that peritonitis may cause patient death. That's why again, yes, abdominal pain may be benign, but to say that this is benign should exclude all severe possible causes of such pain. But don't forget that actually abdominal pain may be not only due to intestinal problems. Again, I told you already about abdominal form of myocardial infarction. In this case, also we see some pain in abdomen. It may be due to some metabolic causes, for example, pain in case of diabetic ketoacidosis. It may be pain due to some vascular disorders. A lot of possible conditions which cause abdominal pain. Don't forget about, for example, women's. And they may experience some abdominal pain due to sex organ problems and very severe problems like severe gynecological bleeding. Severe gynecological bleeding may cause first pain, then bleeding again without care, without help. Actually, patient may die. And that's why I also told you that if you have a woman who presented some low abdominal pain, First question should be not about her food, how she eats, and so. First question should be, when was your last menses? Because if it's delayed, it may cause so-called extrauterine pregnancy, which may cause rupture of tubes, severe bleeding, and death. And first sign, this is some acute, sudden acute pain somewhere in abdomen. So, if patient presented with abdominal pain, you should ask standard questions describing this complaint. Which questions? Again, cite where it is. Please show me where is the pain. Where the pain? Why site is important? Because in most of cases, pain corresponds underlying organ. For example, if it's upper abdominal pain, you think about stomach, for example. Right hypochondrium, no, this is liver and gallbladder. Left hypochondrium, pancreas. Actually, lower right quadrant of the stomach. No, everybody know about actually appendix. Yeah? So again, localization or site of the pain, and again, just ask patient, please show me where is the pain, because patient doesn't know anatomy. Intensity, the character, duration, frequency of the pain, aggravating relieving factors, associated symptoms, including non-gastrointestinal symptoms. Now you see how many questions you should ask, And again, each question may give you some ideas, So, epigastric pain. If we talk about upper abdominal pain, epigastric pain, epigastrium, the upper part of abdomen. Epigastric pain is very common and is often a dull ache, but sometimes sharp and severe. Its relationship to food intake should be ascertained, and it's a common feature of peptic ulcer disease, also occurs in functional dyspepsia. Again, upper abdominal pain, this is usually stomach. It is either peptic ulcer disease and peptic ulcer disease presented with pain. Why we ask about food? Because it's very important. If actually pain happens not just half an hour after meals, it means we should remember physiology. Half an hour after meals, where is food? In the stomach. And if presence of food in the stomach induces pain, what does it mean? Something wrong with stomach. What wrong? No, in many cases, this is peptic ulcer, maybe, that. But just imagine, if pain happened, patient tells you, I have pain after meals, but it happened not soon after meals, but 2 hours after meals. In this case, we talk about late pain. We have early pain and we have late pain. If someone complains of late pain, what we should think about? Again, remember physiology. 2 hours after meals, where is our food stop? 2 hours after meals, food should leave stomach and move to duodenum, shift to duodenum. And what we have? We have duodenal ulcers. And that's why in case of late pain, we think about duodenal ulcers. So one question, early pain, late pain, and we already can imagine where is ulcer? In stomach or in duodenum? In some cases, pain after meals, this is not result of peptic ulcer, some damage. We have so-called functional dyspepsia. Idea of functional disorders. No visible damage of organ structure. In case of functional dyspepsia, we examine stomach, we do fibroscopy and find nothing, no signs of ulcer, no signs of inflammation, but patient experience pain. It does mean that patient liar, patient don't tell us the truth. It's happened, it's functional disorders when problems with functions, not with morphology, not with structure. But to detect this, you should do all investigations and find out that no morphological changes. Right hypochondrial pain, the upper part of the abdomen on the right side. No, this is usually from gallbladder or biliary tract. I told you that hepatic problems rarely cause actually some pain. Acute pain in upper right hypochondrium, right hypochondrial pain. This is usually gallbladder. What? Cholecystitis or cholelithiasis, the gallbladder stones, cholelithiasis, gallbladder stones, also a very common cause for actually some pain in right upper part of the abdomen, right hypochondrial pain. No, sometimes even peptic ulcer, stomach, everything closed. You know, in medicine, nothing for 100%. And we have exceptions like infarction, usually chest pain, but sometimes abdominal pain. And again, cholecystitis, usually right side, but sometimes somewhere in the middle of the abdomen. Chronic, often persistent pain in the right hypochondrium is a frequent symptom in healthy females suffering from functional bowel disorders. No, this chronic pain is not due to gallbladder disease. Again, functional disorders. Functional disorders, sometimes someone believes that if no structural changes, no ulcers, no stones, this is something it can't be. But in some cases, patients present with a lot of symptoms without visible reasons. In these cases, we talk about functional disorders. Functional disorders. Left side, left hypochondrium, this is usually pancreas. Again, remember anatomy, left side hypochondrium, this is usually pancreas, pancreatitis. Lower abdominal pain, lower abdominal pain. Acute pain in the left iliac fossa, usually colonic in origin. No, because again, you studied anatomy. What we have in left iliac fossa. This is large bowel. This is sigma. This is sigmoiditis. No, this is some problems with colon. Chronic pain is most commonly associated with functional bowel disorders. Functional bowel disorders. In females, lower abdominal pain occurs in a number of gynecological disorders, and the differentiation from GI disease is often difficult. It's often difficult. In this case, you need help of gynecologists to understand what is it, our problem or gynecological problem. Right iliac fossa, everybody knows this. What? This is appendicitis, acute appendicitis, inflammation of appendix. You know, what for we need such small piece of tissues which known as appendix, Sometimes ago, people believe that this is just useless stuff. This is just useless stuff, and they suggested let's remove it. You know, people just to avoid appendicitis. Now we believe that we don't have something actually absolutely useless in our body. In this appendix, we have a lot of lymphoid tissues. This is some place where our immune system present and trained and live. And what else? Actually, this is place where our microbes can survive in some catastrophes. For example, we take actually antibiotics, treating, pneumonia. Antibiotics, this is like actually some bullets. They don't actually separate good microbes, bad microbes, they kill everybody. And I told you already that we can't live without microbes. And for our bacteria, appendix is some kind of shelter. This is place when can they survive and then again colonize our bowel when this treatment using antibiotics stop. That's why we don't have something actually useless in our body. But again, inflammation of appendix may cause serious consequences, and it should be diagnosed in proper time. And actually then, and you know about actually localization. I told you, right lower part of abdomen, appendicitis. But you know that surgeons will tell you about even one sign. I can't remember name of this sign. But usually in appendicitis, pain starts in epigastrium, in upper part of abdomen, and then move to right iliac fossa, And this is one of signs of appendicitis, one of signs of appendicitis. Okay, next sign, weight loss. Next sign, weight loss. No, weight loss is usually due to anorexia, loss of appetite, and is a frequent accompaniment of all gastrointestinal disease. Anorexia is also common in systemic disease and may be seen in psychiatric disorders, particular anorexia nervosa. I told you about this. You know, bad appetite is one of signs of depression, for example, or one of signs of severe depression. Anorexia often accompanies carcinoma, but it's a late symptom and not of a diagnostic help. Yes, in case of cancer, sometimes patients experience loss of appetite, but usually it's happened on late stage of cancer. When one patient tells you, no, doctor, I have no appetite. I eat nothing. First question should be, what about your weight? And if patient tell you, no, nothing wrong with my weight, I have bad appetite, but my weight is normal. It's not real bad appetite, because real sign is a weight loss, because if patient eat nothing, he should lose weight. If he gain weight and tell him that he has a bad appetite, it's not true. Malabsorption. What is malabsorption? Patient may eat normally, but food should be digested and absorbed, and it's happened in intestine, mostly in small intestine. And malabsorption is when, due to different disorders, this food stuff can be absorbed and enter our blood. In this case, we talk about malabsorption. No, usually, we rarely see such stuff because we have long 5 meters intestine. And rarely disorders damage all 5 meters. That's why actually what we eat now, we eat already digested food, because cooking, boiling, frying, what is it? What we do? We break down big molecules. We prepare food for digestion. You know that we have many people after surgery without stomach. No stomach. Stomach was removed due to cancer, for example. And how patients survive? Normally survive. They can absolutely normally live without stomach just because they eat actually already cooked food. Weight loss should be assessed objectively, if patients often think that they have lost weight. And this is what I told you. Just wait patient and compare his weight during some last weeks, month, and even we have real decrease in food, in weight. This is real actually weight loss. By the way, we have such thing as bad appetite, but we have also such thing as so-called cytophobia. Cytophobia, phobia is afraid of something. Phobia, afraid of something. Sometimes patients, they have good appetite, but they're afraid of food. Why? No, I gave you example. Peptic ulcer disease. Patients after meals experience very severe pain. This leads to nausea and vomiting, and then relief. And then patients think about this. What for I will eat to experience pain, then to vomit? I just eat nothing, or I just eat less. I eat less, I have less pain. And in this case, we talk about not bad appetite. Appetite, patient eager to eat, but he afraid of food. In this case, we talk about cytophobia, cytophobia, cytophobia. Okay, clinical examination, clinical examination. Of course, we can use different types of physical examination. This is palpation, percussion, auscultation. You know about all these methods of investigation. And for examination of abdomen, mostly important, this is palpation. For example, for heart disorders, the most important auscultation. But for GI problems, or more important, this is palpation. No, palpation, percussion, I may say, palpation, percussion. When we do all these investigations, we should be able to describe what we find, where we find, and that's why let's talk about anatomy. For descriptive purposes, abdominal cavity generally divided into 4 quadrants. 2 imaginary perpendicular lines cross at the umbilicus to divide the abdomen into the right upper and lower quadrants and the left upper and lower quadrants. One line extends from the sternum to the pubic bone through the umbilicus, and the second line is at right angles to the first at the level of the umbilicus. Now just imagine, we just divide actually abdomen into 4 areas. And that's why easy to actually say where it is. Right upper, left upper, right lower, the left lower. But usually in our clinical practice, we use another actually anatomical approach, You see, we divide our abdomen into 9 areas. We have 2 lines. This is lower edges of ribs that connect lower edges of ribs. And what above this line, we talk upper part of abdomen. And then actually we divide, and actually we have also 2 vertical lines. These 2 vertical lines just follow edges of musculus rectus abdomen. Remember, musculus rectus abdomen. This is muscles, good, visible in sportsmen, in people who have a good actually muscles. So as a result, we have 9 areas. Again, epigastric, mesogastric, upper-umbilical, and suprapubic. 3 areas. This central this upper part epigastric. We discussed already what we have here. Usually stoma. We have paraumbilical. Paraumbilical. Usually we have here small intestine. Here we have small intestine, loops of small intestine. Now suprapubic. No, this is usually, actually, we don't have gastrointestinal organs. In women's, this is sex organs, or this is bladder, which also plays somewhere here. But then what we have? Again, left hypochondrium, right hypochondrium. These triangles on the left or right side, we talk about left hypochondrium and right hypochondrium. Again, left, this is pancreas, right, this is gallbladder and liver. Gallbladder and liver. Then we have right lumbar and left lumbar area, right lumbar and left lumbar. Sometimes we also use terms flanks of abdomen, flanks of abdomen, left or right. What we have here, usually this is a standing part of actually a large bowel, a standing or distending part of large bowel. And again, right inguinal and left inguinal area. Right inguinal, again, appendicitis, appendix. Left inguinal, here we have sigma. Here we have sigma. We have sigma. Okay. How we start our physical examination? Just inspection. Just watch. Just watch patient, see patient abdomen. What we can see on observation, just on looking around. We can find, for example, abdominal distension, enlargement of abdomen, big abdomen, enlargement of abdomen, abdominal distension. It may be due to flatus. Rarely patients have such big amount of gas in his abdomen to make it like a balloon, to make it like a balloon. Fat, it's more common. We have a lot of fatty people, and sometimes we have very thick actually fat tissues. In this case, this is due to fat. Fetus, it's clear, pregnancy. Fluid. Fluid, this is accumulation of actually water in abdominal cavity. And this is usually which term we use? Ascites. Ascites. This is accumulation of fluid in abdominal cavity. Now, usually this is result of some very serious disorders. It may be cancer, it may be liver cirrhosis. Usually this is causes of actually ascites, usually causes of ascites. Now, feces theoretically, due to again complete blockage of actually intestine on some level, it may cause accumulation of feces. Sometimes cavation of vertebra, like lordosis. We have kyphosis and we have lordosis, may give some appearance of distant abdomen. After examination, no, by the way, during examination also we should assess shape of abdomen, symmetry of abdomen, presence of scars on abdomen. Because if patient has some pain in right inguinal area, but you see big scar in this area, no, it means what? It was appendectomy. We don't have two appendixes. And if it was removed once, it's impossible to have appendicitis one more. Palpation. The abdominal organs may be felt in some normal subjects, but it's not common. Such organs usually only just palpable. No, palpation is more practical case, and during your practical classes, teachers will show you how to do palpation. No, you should just know that actually which organs may be palpated. No, healthy liver only in less than 50% of cases. Usually liver becomes palpable in case of hepatomegaly, enlargement. When liver goes down, it becomes palpable. Kidney, very difficult to palpate, you see, if they are normal. What else? No, actually, large bowel, more or less palpable. For example, sigmoid colon may be palpable in 75% of cases. Small bowel, difficult to palpate because it's very movable. You can't fix it, you can't feel it. No, on palpation, any palpable mass is carefully felt to decide which organ is involved and also to evaluate its size, shape, consistency, whether it moves with respiration. No, hernial orifices should be examined. You know, idea of hernias. Hernias, this are openings which let intestine move out under skin. That's why idea of hernias. No, surgeons will tell you about hernias much better than me. Succussion splash. You know, again, just do one experiment. After being in your room, in flat or hostel, after breakfast or after dinner, when you drink some tea or some other beverages, just lie down on your back and using your hand, just press your abdomen in the projection of stomach, in upper epigastrium, And if you press, in some cases, you feel splashes. You feel splashes like water. What is? No, this is splashes of water in stomach. And this is why it's known as splashes. It's normal. But remember what I told you. Usually food and water stay in stomach only from 1 to 2 hours and then disappear. If you do it when you are hungry, you may press a lot, but you hear nothing. But just imagine, you have a patient tell you that he ate 3 or 4 hours before visiting you, but you still can hear splashes. What does it mean? For some reason, water and food can't move from stomach. And we know such condition, outlet obstruction or pyloric stenosis. Again, using such very simple methods, you can detect, you can imagine, you can think about some very specific and serious conditions and to find out some diagnose, find out some proper diagnose. No, this is just CT scan of patient. Just imagine where is all this stuff. You see, this is actually vertebra, this is big organ, this is liver, this is right side. You know, when we examine CT scanning, we see from bottom, from patient feet, and that's why if you see from patient feet, a liver appear on the left, on the right, on the left side of the picture. This is right side of the patient. What else we see? This is pancreas. This is aorta. This is aorta, big vessel. This is pancreas. this is pancreas, this is spleen, this is spleen which placed on the level of actually liver on the opposite side. No, this is some part of kidney, and this is stomach, by the way. You see, stomach contain air because stomach contain bubble, air bubble. When we eat, we swallow some air and stay in actually stomach. This is some loops of intestine, some loops of intestine. Percussion. Percussion usually we use to detect the area of dullness caused by liver and spleen. No, sometimes possible blood enlargement. Again, by percussion, we can detect difference between density of organs. Because again, very dense organs, airless organs like liver, they produce dull sound, Yeah? Air-filled organs like intestine, they produce clear sound, sometimes called tympanic sound, like a drum, we beat like a drum. Yeah? And feeling difference between liver, dull sound, and intestine, you can detect by the way size of liver, presence of enlargement of liver, absence of enlargement of liver. Also, you can detect size of spleen. Sometimes you can detect presence of water in abdominal cavity. Because also water gives dull sound. It's interesting that what is movable. And if patient lie on his back, where we detect this dull sound? On the left and right side. But if patient turn on the right side, on the left side, this dullness disappears because all water moves to the opposite side. Again, then patient move on the left side. Again, right side becomes clear. Just finding this, you understand this is not organ. This is something movable. What may be movable in abdominal cavity? No water. This is the only sign of ascites. No, auscultation is not a great value of gastrointestinal disease. No, just one tip. Just take phanendoscope and apply to your abdomen. You will hear so-called abdominal breath because our intestine contracts. Some stuff move intestine, causing some bubbling sound because we have air, water in intestine, and this is absolutely normal. Dangerous condition when no sounds, silence. You apply phanendoscope, silence for a long time. It means that we have paralysis of intestine. No work of intestine out of order, and it's very dangerous. It may be a sign of peritonitis, for example, a sign of peritonitis. Okay, this is usual physical examinations we use to describe actually to detect gastrointestinal problems. Okay, it's enough for the first lecture. If you have questions, please, you may actually write something in the chat. Так, слышь, что мне писали, что микрофон выключен. So I know that at the beginning of lecture it was some problem, but actually we changed this. Again, if you have some questions, please type in Zoom chat. No questions. No, okay, if no questions, again, one more. Guys, if you still don't know your group number, don't worry. During today or maximum yesterday, we'll check everybody who are here, who are out of Russia. We'll actually put you on the list, and you'll find yourself in one or another groups. I tell you that we will change someone groups or something. We don't have time for this. We fix and just start your studies. Maybe next semester, next year, we can do something, but not right now. Okay, if no questions, thanks a lot and see you in 2 weeks. Now we have this semester, we have only 2 lectures per 1 month. 2 lectures per month. Good luck. Bye-bye.